Good evening, all. Now I will start. Okay. So today's topic, only 13, I am seeing 19 participants. Okay, I can start now. So you know probably that today we will discuss on two topics. One is neonatal hypoglycemia and the second topic is emergency triage, assessment and treatment. Okay. So first we will discuss neonatal hypoglycemia. Okay. So after end of this webinar, probably you will be able to define hypoglycemia. You will be able to identify neonate at risk of hypoglycemia. You will be able to explain how to estimate blood sugar in neonates. And you will be able to manage a neonate with hypoglycemia. So I am asking one question to Dr. Sneha. Dr. Sneha, can you hear me? Okay. Okay. I don't think you will unmute yourself. Okay. So you know there are a lot of confusions about this definition of hypoglycemia. So it is defined as blood sugar less than 45 milligram per dl. And you know probably this is one of the commonest metabolic disorder in newborns. And also to some extent you know that this hypoglycemia can lead to long-term sequelae. So anticipation, prevention and early treatment can reduce mortality and morbidity. Then who are the neonates at risk of hypoglycemia? You know, it's the preterm babies and the low birth weight neonates. Can anybody say why the preterm infants are at risk of hypoglycemia? Okay. So you know probably the reserve is less for hypoglycemia to maintain normal glycemia. So glucose should come either from feed or from the fluid or from the body should generate glucose from glycogenolysis or neoglucogenesis. So in a preterm baby, the reserve is low, so that's why preterm baby can develop hypoglycemia. Infants of diabetic mothers, can anybody say what is the reason why an infant of diabetic mother will develop hypoglycemia? I have seen 29 participants have joined. Dr. Meenakshi. Nobody. Okay. So infants of diabetic mothers, you know, because maternal hyperglycemia, because of that reason, so blood sugar will pass to the placenta and that will stimulate the fetal pancreas. So that will lead to hyperinsulinemia in the fetus. So after birth, that insulin level will decrease the blood sugar in the neonate. So that is the reason the neonate will develop hypoglycemia. Small for gestational age neonates, the reason is same, the reserve is less. And in case of infant intrauterine growth retardation also, the reserve is less. So that's why the neonate can develop hypoglycemia. Maternal intake of drugs like beta blockers, you know, probably. So this will lead to prevention of epinephrine-induced glycogenolysis. So the neonate can develop hypoglycemia if mother is taking beta blockers for hypertension. Neonates requiring IV fluids. So if there is interruption of IV fluids because baby is getting only glucose from that IV fluid. So if there is interruption of that delivery of sugar level, so that lead to hypoglycemia. Any sick neonate, so it can be because of perinatal asphyxia, sepsis, hypothermia. And so in this situation, there could be increased utilization or maybe Okay. So this will lead to hypoglycemia. Now question, those who are at risk of developing hypoglycemia, how frequently we will monitor blood sugar? So the standard, you know, probably that we should screen all neonates at 2 hours of life after birth, at 6 hours of life, at 12 hours of life, 24 hours of life, at 48 hours of life, and after 72 hours of life if it is required. So this is standard guidelines. Neonates on IV fluids, it is better to screen every 8 hourly. And if the neonate no longer requires IV fluids and two readings 12 hourly are normal, we can stop monitoring of blood sugar. Then technique of estimation of blood sugar. So this is one of the important thing, because based on this report, basically we are deciding whether baby is maintaining normoglycemia or not. So this is one of the most important thing. So some of the do's, what we do, side, usually we check blood sugar from the heel prick, or sometimes we club it together from the peripheral vein if we are doing some other investigations as well. So I will show you the picture from which place you will do the heel prick. The heel should be warm. Many times it may happen, even if at this neonate. So even if the baby is staying with mother in the postnatal ward, even in summer season, where outside temperature is 45 degrees centigrade, still baby may have hypothermia. So heel should be warm, because we know once the baby is in cold stress, the heel and the palms and soles are cold to touch and the abdomen is warm. So heel may be cold. So heel, before doing blood sugar estimation, heel should be warm. And the method to make it warm is different. So whatever practice you are following, I do not know because you are not responding. So then prepare the site with 70% isopropyl alcohol and allow to dry that spirit, and then prick the posterolateral aspect of the heel. I will show you the picture. Send a lab sample if blood sugar is low. So as we have defined that blood sugar less than 45 milligram per DL is the threshold for action. So if blood sugar is anytime in the glucometer, it's less than 45 milligram per DL, it is better to send a lab sample, but don't delay for the management. So this is the picture of the heel. If you draw a line from the little finger and the great toe, and if these two lines meet at the periphery, so lateral and medial aspect of that side, posteriorly is the ideal. So if you can see the picture here, the lateral side and the medial side, medial aspect. So these are actually safe place for obtaining capillary blood sample from the heel. Don't puncture the posterior aspect, because calcaneus is there, we may damage calcanea. So later complication may happen like osteomyelitis and other things. Then some do nots are there. So heel should not be cold to touch, as I have mentioned earlier many times. Even if the outside temperature is 45 degrees centigrade, still, and if the baby is staying with mother also, then also heel could be cold to touch. So once you are planning to do, or the nursing officer, they are planning to do blood sugar estimation, first monitor that heel is not cold to touch. If it is cold to touch, then make it warm, and then only plan for pricking. Avoid pricks in the middle portion of the heel. As I have mentioned, calcaneus is very underneath the skin and subcutaneous tissue. So we may damage, and later it may develop some complications like osteomyelitis. Avoid deep pricks. Povidone iodine should not be used for skin preparation, because falsely the blood sugar may be high or low. Delayed lab analysis. Delay in analysis may result in falling plasma sugar by 14 to 18 milligram per DL per hour. So if you are keeping the sample without not sending the sample to the lab, falsely low value may come. So it is better once you are planning to send the sample immediately to the lab. And you know, probably you are taking sample in chloride sample, so that prevents basically the enzyme enolase, so that prevents glycolysis. So so we should take that sample, lab sample in chloride vial. Regarding symptoms of hypoglycemia, probably you know it is the symptoms because of the blood sugar low in the CNS. So baby can be, the neonate can be irritable, or you can see jitteriness, and maybe if it is prolonged, so then baby may be lethargic, or baby may have, because of irritability, poor high pitch cry, and simultaneously there may be poor feeding. And the other symptoms like baby may have tachycardia or tachypnea. Sometimes if it is a preterm baby, there can be apnea as well. And you may in a term babies can see sweating, and finally you can see the seizure as well, convulsion. So always remember, once you are getting multiple signs and symptoms like this, so consider at least two things. One is sepsis in neonate, and second is probably perinatal asphyxia. And the third and fourth is hypothermia. Always remember, in neonatal any cause, so hypothermia can be the underlying cause. And as hypocalcemia may present with some these manifestations of hypoglycemia, we can think of hypocalcemia as well. Check blood sugar in every sick neonate, as we have mentioned earlier. And if signs are not alleviated after correction, consider other diagnostic possibilities. As I have mentioned, so different diagnoses are like here I have mentioned about 4 differential diagnoses. And then once you will diagnose, or once it is not diagnosis, basically it is the operational threshold. If it is below 45 milligram per DL, then we need to consider for treatment. Okay. So once you are considering for IV infusion, so we remember this glucose infusion rate. So glucose infusion rate, once any baby is developing hypoglycemia, to maintain normoglycemia, usually we start with 6 milligram per kg per minute. But how do we calculate that? So if you are using 10% dextrose, probably on day 1, day 2, usually we use 10% dextrose, not saline. And the fluid rate, depending on the body weight, birth weight of the baby, whether it is more than 1,500 gram or it is less than 1,500 gram. So depending on that, you will put that figure, day of life, the ml per kg per day, and the percentage of dextrose divided by 144, you will get the glucose infusion rate. And then management of hypoglycemia, as I have mentioned, so it is not the diagnosis, it is basically the operational threshold. So once blood sugar is less than 45 milligrams, what is the normal blood? Anybody can say what is the normal blood sugar in a neonate? I am only seeing here Manasi. Manasi, can you say? Achha, Oindrila, can you say what is the normal blood sugar? Okay, you are not responding. Okay, so normal blood sugar is usually 70 to 110 milligram per DL, but it's okay. And here, once the blood sugar level below 45 milligram per DL, so that is the threshold for treatment. So then we consider to treat that child. Now, as I have mentioned, signs and symptoms of hypoglycemia, so that newborn can be asymptomatic or can be symptomatic. So we will first discuss about the management of an asymptomatic neonate. So now, if blood sugar is more than equal to 25 milligram per DL, in that situation, give measured feed 20 to 30 ml. Okay, it can be express breast milk or it can be donors if breast milk bank is available, donors milk. And then after giving feed, check blood sugar. Always remember, I have not mentioned earlier that once we are doing the screen, so once we will check blood sugar, it is pre-feed blood sugar, it is not post-feed blood sugar. Here, but once you are managing the blood sugar, after starting treatment, here check blood sugar after 1 hour, because now you need to think what is the blood sugar. Based on that, you will decide further management, further course of management. So here, if blood sugar again after 1 hour, if it is more than 45 milligram per DL, this is the threshold action. So frequent breastfeeding, if baby is on breast milk, glucose, and monitor blood sugar every 6 hourly pre-feed. In other situations, so if blood sugar is less than 45 but above 25, or blood sugar is less than 25 milligram per DL, even after giving a feed, measured volume feed after 1 hour, so then what we do, we start with 10% dextrose. So if baby's blood sugar is 25 to 45, then we do not give bolus. But if blood sugar is less than 25, then we give a bolus 2 ml per kg IV. And in babies whose blood sugar is in between 25 to 45 milligram per DL, in those situations, we straightforward start with IV fluid, as I have mentioned earlier. So that is glucose infusion rate at 6 milligram per kg per minute. And if the baby is symptomatic, so in any situation, so we usually give a bolus of 2 ml per kg of 10% dextrose. And then we start IV fluid. at GIR of 6 milligram per kg per minute. Once you will start fluid, remember, once you are giving feed, you are checking blood sugar after 1 hour, but here you will check the blood sugar after 30 minutes. So now again, two things may happen. One thing is that baby's blood sugar is now more than 45 milligram per DL. Then usually begin oral feeds, monitor blood sugar every 6 hours, as I have mentioned so earlier also. But it can happen that baby's blood sugar still less than 45 milligram per DL. In this situation, so increase glucose infusion rate by 2 milligram per kg per minute. And always once we are increasing that GIR, check blood sugar after 30 minutes. Now if blood glucose is more than 45 milligram per DL for 24 hours, taper GIR by 2 milligram per kg per minute every 6 hourly. And at the simultaneously start oral feeding and monitor blood sugar every 6 hourly. But it may happen also that blood sugar is still less than 45 and GIR is more than 12 milligram per kg per minute. So that is basically refractory hypoglycemia. In this situation, for peripheral level, you may consider to start injection hydrocortisone 2.5 milligram per kg twice daily. Remember that up to 12.5% dextrose can be administered through peripheral vein, because most of the times, if baby is developing hypoglycemia, we do not put central line. We usually start with IV fluid through peripheral lines. So if anytime to maintain the GIR, if concentration of the dextrose is going above 12.5%, then probably central vein is required, central venous access is required. The resistant hypoglycemia, if hypoglycemia is persisting despite GIR of 12 for more than 24 hours. Prolonged or recurrent hypoglycemia, if it is persisting after 7 days of life. Is it clear? This is the chart to calculate GIR once we are using 10% dextrose in the beginning. So as you have seen in the left side, left column, it is the volume of fluid, because so this is meant for more than 1,500 grams. Usually we start day 1 with 60 ml per kg per day. And every day we increase by 15 ml per 15 ml. So finally on day 7, baby should get 150 ml per kg per day. So based on that, once we are mixing 10% dextrose and 25% dextrose to make GIR 6, 8, 10 here for instances. So it has been mentioned, because day 2 up to day 2 you will use 10% dextrose. Subsequently you will add normal saline. We need to keep in our mind. So it is there in that calculation. Okay, and normal saline means it is n by 5. So if total fluid is 100 ml, 20 ml saline and 80 ml dextrose. So dextrose again, it is 10% dextrose and 25% dextrose. So this is simple chart. You can have that chart in your unit, because it would be very easy to put for you as well as for the nursing officer to start with. Many times it may happen once you are starting calculation, after calculation it can give something error and you get wrong things. So you can use this chart, or you can use some apps also. Now apps are available. So if baby's birth weight is less than 1,500 grams, you know, left side again. So usually we start with 80 ml per kg per day on day 1. And finally on day 7 or day 6, the baby should get 150 ml per kg per day. Again, based on the requirement. So you see day 1, day 2 only dextrose, and day 3 onwards it is saline, n by 5 saline. Okay. So it can be GIR of 6, it can be GIR of 8, it can be GIR of 10. Okay. And then always remember, risk of neurodevelopmental sequelae like seizure, developmental delay, neurodeficit can be there. So for these babies should require regular follow-up to monitor developmental status. So key messages are, hypoglycemia is a common problem in preterm low birth weight 6 neonates and infant of diabetic mother. Hypoglycemia can cause brain injury with long-term neurodevelopmental impairment. Neonates at risk of hypoglycemia should be screened. Early breastfeeding and frequent feeding helps to prevent hypoglycemia. Neonates with hypoglycemia should be followed up for neurodevelopmental status. So I think I have completed the first part, that is neonatal hypoglycemia. Do you have any question? Do you have any question? I am just getting okay. Indrila, do you have any question? I cannot hear you. You unmute yourself. Unmute yourself. Do you have any question? Anybody? Anything needs clarification? I have intentionally stopped my video because of network issues. So you can ask me questions. I can see you, not all, but 45 participants are there, 44. But I can see some of you. Okay. Now I can't see anybody. So if you do not have any questions or if you do not need any clarifications further, then we can move on to the next topic, that is ETAT. Okay. So ETAT means probably this is emergency triage, assessment and treatment. In short form, it is ETAT. So triage means sorting. So why is it important? It is important to avoid procedural delays in initiating emergency treatment and rapid screening of neonates who require immediate attention for life-threatening conditions. Learning objectives are to understand the process of identification of sick neonates requiring urgent attention and carry out ETAP of all sick neonates when they arrive at a health facility. So how do we do that? Steps of management of sick neonates. Sick newborns are triaged into the following categories. So there are three categories. One is emergency situation, priority situation, and non-urgent situation. So once it is emergency, so emergency treatments are required. In priority situation, it is better to assess and then depending on that, take rapid action. And in non-urgent situation, it is assessment and counsel the parents. Once emergency signs are identified, so first thing should be stabilize the neonate. After stabilization, only take the history and perform relevant examination and do follow relevant laboratory investigations to arrive to a diagnosis for further management. After deciding the main diagnosis or any secondary diagnosis, treatment should be started. It can be specific or it can be supportive. Then monitor the baby closely for response to treatment. And once you are discharging, explain mother the danger signs and advice for follow-up. What are the emergency signs? So if hypothermia, temperature is less than 35.5 degrees centigrade, the neonate is apneic or showing gasping respiration, severe respiratory distress, rate is more than 70 breaths per minute, severe retractions or grunting, central cyanosis, baby is in shock, cold periphery, or capillary filling time is more than 3 seconds, or weak or fast pulses, you are getting either or baby. Is it okay now? Can you hear? Can you hear me now? Can you hear me now? Can you hear me? Okay, sorry. I do not know. Should I repeat again from since when you couldn't hear? I do not know. Okay, I'm starting from this. As I have mentioned, three situations can arise. One thing is that emergency situation, priority situation, and non-urgent situation. In emergency situation, first we should stabilize the neonate, and then we take history and exam, and then we do some laboratory investigation, and based on that we will arrive to a diagnosis, and after that we will start specific and supportive treatment. Okay, and then you will monitor the baby, and then after discharge you will ask the parents, explain the danger signs and ask them for follow-up. Emergency signs are hypothermia, apnea or gasping respiration, severe respiratory distress, central cyanosis, shock, coma, convulsions, or encephalopathy. Here, all these situations require urgent intervention and emergency measures. First, should be stabilized and admit to the SNCU. So we have discussed the emergency signs. Now, the priority signs. It's low birth weight neonate, weight is less than 1,800 gram, temperature in between 36.4 and 35.5 degrees centigrade. Respiratory distress, it is more than 60, but minimal retractions or no retractions. The neonate is irritable, restless or jittery. There is history of refusal to feed, abdominal distension. The neonate may have severe jaundice, appear within 24 hours, and it is staining palms and soles, or it can be it is lasting for more than 2 weeks. Severe anemia, bleeding from any side, major congenital malformations like tracheoesophageal fistula, anorectal malformation, or meningomyelocele, or it can be a large baby more than 3.8 kg, or large for gestational age according to the percentile charts. All these are priority signs. So in priority, where we will get priority signs, then actions should be required, immediate assessment, and need to be attended on a priority basis. Also need to be admitted to the SNCU. So I have intentionally made it green because you know probably in casualty or emergency there are three signs: red, yellow, green. So it is means the zones like non-urgent signs. So the jaundice, transitional stools. There are developmental peculiarities, minor birth trauma, posseting, superficial infections like eye infections or skin infections, minor malformations that doesn't need immediate interventions. All cases not categorized as emergency or priority. In this situation, if you know the diagnosis, then reassure the mother, counsel the parents. So here the same thing is again I am showing in chart. Probably those who are following facility-based newborn care guidelines, so you will get that in that book. It has been taken from that book. So as I have mentioned, so there are three categories. Once we are thinking about emergency triaging, assessment, and treatment. So we categorize into three: emergency, priority, and non-urgent. Emergency signs I have already explained you. Hypothermia less than 35.5 degrees centigrade, apnea or gasping respiration, severe distress, rate more than 70, severe retractions or granting, central cyanosis, shock, coma, convulsion, or encephalopathy. So here, if neonates with emergency signs are at high risk and require urgent intervention and emergency measures, these neonates with emergency signs after stabilization are to be admitted. Priority signs I have mentioned. Action: neonates with priority signs are sick and would need immediate assessment. They should be attended to a priority basis. These will also need to be admitted to SNCU. And some signs are non-urgent like jaundice, transitional stools, developmental peculiarities, minor birth trauma, posseting, superficial infections, minor malformations. All cases not categorized under the heading of emergency or priority. In neonates with no emergency or priority sign, proceed with assessment and further treatment according to the neonate's requirement. How to triage? So triaging area, the reception and the resuscitation area of the casualty or of the hospital. So that can be, it depends on the situation. All the staff should be trained in triaging process. The most experienced doctor trained in neonatal care should take the responsibility of emergency treatment, considering the T, A, B, C, D steps, like T for temperature, A for airway, B for breathing, C for circulation, coma, convulsion, and D for dehydration. So we will look for that one by one. You know that probably this chart. So assess for emergency signs in all cases, and on the right side, make sure that neonate is warm. Give appropriate treatment for positive emergency signs. Call for help. Draw blood sample for hematocrit, glucose, calcium, and sepsis screen. Like first, as I have mentioned, T, A, B, C, D, the rule. Temperature, T for temperature, cold to touch. Compare palms and soles compared to the abdomen. If baby is hypothermic or temperature is low, then rewarm the hypothermic neonate. Make sure the neonate is warm. Then look for A and B, that is airway and breathing. So in this, you can see the signs. So first, not breathing, baby is apneic or gasping. Or if not, then baby's respiratory rate is more. So respiratory distress can be more than 70. Severe lower chest retractions. Then look for cyanosis, central cyanosis, and other features of respiratory distress, that is granting. Any sign positive, any of these positive, then manage airway. You know probably NRP guidelines. Give oxygen and make sure neonate is warm. Again, C for circulation, cold extremities with capillary refill longer than 3 seconds. Weak and fast pulse more than 160 beats per minute. If positive, give oxygen. Make sure neonate is warm. Insert IV line and give 10 ml per kg normal saline bolus over 30 minutes. Proceed immediately to full assessment and treatment. So baby can be in shock for different reasons. So first manage that shock and then assess and examine and then manage the baby's start treatment according to the specific diagnosis. Then C, I mentioned earlier, so circulation, coma, and convulsion. So the child can be seizing. If coma and convulsion is there, then manage the airway first. Then check blood sugar once you are putting cannula, or even if you are not putting cannula. If convulsions, if baby is has developed the features of hypoglycemia, then manage hypoglycemia. If not, then if convulsions continue, give IV calcium. And if convulsions further continue, then give anticonvulsants. You know, either you can give phenobarb or phenytoin. Then look for dehydration. So diarrhea plus any two of these, so baby is lethargic, or sunken eyes or very slow skin pinch. Diarrhea plus 2 signs positive. Make sure the neonate is warm again. Insert IV line and begin IV fluids rapidly following plan C. Check temperature if the baby is cold to touch or warm. If there are no emergency signs, look for priority signs. These neonates need prompt assessment and treatment. So I have mentioned earlier what are the priority signs. So again, I am telling that birth weight less than 1,800 gram or more than 3,800 gram. Temperature in between 35.5 to 36.5 degrees centigrade or more than 35 degrees centigrade. Lethargy, respiratory distress, rate is more than 60 beats per minute, bleeding from any source, birth trauma, pallor, and abdominal distension. Non-urgent, proceed with assessment and treatment further according to the neonates priority. If a neonate has surgical problems, get surgical help or follow surgical guidelines. So now we will discuss cases, but you are not responding. I do not know how to discuss cases. So this is the first case. A 3-day-old neonate with birth weight of 2.4 kg is brought to the SNCU with a complaint of inability to feed. So here I have mentioned the temperature is 36.2 degrees centigrade. Baby appeared lethargic. Capillary refill time is 2 seconds. Hands are cold. The breathing rate is, respiratory rate is 55 breaths per minute. Heart rate is 144 beats per minute. So anybody from your side can say where, if you are examining and assessing this baby, which category this baby will go to, and then how do you manage further? I am only seeing here Ravi Kumar. Ravi Kumar. Ravi Kumar. Can you unmute yourself, Ravi Kumar? Okay. So here the refusal, inability to feed. So temperature you have seen that it is priority sign. So it is not less than 35.5 degrees centigrade. It is 36.2. Baby appeared lethargic. Capillary refill time is 2 seconds. And hands are cold. So if it is not mentioned, temperature has been there. So it is basically cold stress. Baby's breath rate means respiratory rate is normal, less than 60 breaths per minute. And heart rate is also normal. So it is the priority. So it is, that means from your assessment, it's priority. That means, so the diagnosis probably is hypothermia. So the baby is 3-day-old neonate, and that has the neonate has been brought to SNCU or maybe to your casualty or somewhere in the hospital. Birth weight is 2.4 kg. Then how will you manage? I am not seeing anybody. So probably. So here the first is, as I have mentioned earlier, it starts with, so here so the baby is lethargic. So what we do need to do, assess the SpO2 as well. And as the baby is lethargic and inability to feed, then probably you will check blood sugar. And then the next step would be two things. One is baby is hypothermic and inability to feed. So as this baby's weight is 2.4 kg, so you need to assess breastfeeding as well, because the next step would be whether you will continue breastfeeding or you will start something else. So that is one way. And second is, as I have mentioned, so it is TABC, as baby is breathing spontaneously and baby's respiratory rate is normal. Baby doesn't have cyanosis. So I have not mentioned, but from SpO2 you will get the idea. Baby's heart rate is normal, and also there are no signs of dehydration. So here two things you will do. One thing is that, so maintenance of temperature as well as feeding. So priority means here you will decide whether you are going to admit this baby or not. So probably, so if you are assessing the baby for breastfeeding, so that will suggest you. And second is, if capillary blood sugar or blood sugar is normal or abnormal, that will dictate you whether you are going to admit or not. If baby has developed hypoglycemia, you will follow the hypoglycemia management algorithm. Based on that, you will decide. Second step is how you are going to feed the baby, because the complaint was inability to feed. So you will assess for breastfeeding and you will check whether baby is breastfeeding or not. There could be some problem from the baby side. There could be some problem from mother side. So this is 2.4 kg. I have not mentioned, so it's term or gestational age. So this could be and small for dates baby. So again, if this child is small for dates, probably there is a risk to develop hypoglycemia. So this baby could have hypoglycemia. So if you are planning to manage hypoglycemia, how you are going to manage hypoglycemia? Whether this baby, if you are giving fast feed, after giving the fast feed, whether baby is maintaining blood sugar or not, or whether baby is able to feed or not. So that means the first case, the priority signs, as I have mentioned, the temperature and the lethargy, and how you are going to manage, I have discussed. The second case is day 8 old baby, birth weight was 2,600 gram with fast breathing and inability to feed. So temperature was 36 degrees centigrade. Respiratory rate was 74 breaths per minute. Significant lower chest in drawing. Heart rate 156 beats per minute. And capillary refill time 4 seconds with cold extremities and poor peripheral pulses but no diarrhea. So I am not. Okay. Biswajit Mondal. Biswajit Mondal. Can you hear me? Biswajit Mondal. Okay. Aparna Satpathy.
Yes, sir.
Yes. So I have heard. Okay, kindly explain. Okay, I am not hearing anybody. So
This is, sir, an emergency.
okay, just explain what are the emergency signs. You just tell one by one. So there are a lot of signs are there.
Sir, this one is hypothermia, 36 degrees Celsius temperature and respiratory rate more than 70, severe retractions present, CRT greater than 3 seconds, and signs of shock present, sir.
Okay, good. So you have seen everything. Okay. So then how you are going to manage? Means you know probably the principle of management in emergency situations, isn't it?
Yes,
How you are
yes,
going
sir.
to manage? Yeah. So how will you start?
Sir, we will start with temperature, sir. Rewarming would be done. Then we
That
will
means
go according to
your answer is stabilization first, isn't it?
Yes, sir.
Yes. So once you are starting stabilization or thinking about stabilization, probably you are following TABCD, isn't it?
Yes, sir.
Yes. So that's why you are telling temperature, na? So good. So you will take care of the temperature first, isn't it? So
Yes, sir.
then how will you start that? Suppose this has come to your medical college. It can be your SNCU or NICU, or it can be your general casualty or pediatric casualty. So
Yes,
that
sir.
so how we are going to manage temperature. So that means you will
Sir,
keep somewhere
yes,
to.
sir, we will keep under radiant warmer.
Okay, good.
And then, sir, for airway, we will look if any secretions are present. And we
Okay, so
will
here
keep.
baby is breathing, breath rate is more, so 74 breaths per minute, and severe respiratory distress, isn't it?
Yes, sir.
So these are basically airway and breathing. Baby is breathing spontaneously, but it is respiratory distress with significant chest retraction, isn't it?
Yes,
So
sir.
what are you thinking now? So this is a 2,600 gram means baby weight. So if any a down baby or normal weight baby is coming with respiratory distress, so what you will start with? You
Uh,
will start oxygen or you will start something or that's the
yes,
question
sir, we
first.
will start
Baby is
with
breathing spontaneously.
oxygen,
Yes,
sir.
you will start with oxygen. Okay. You
Yes,
will
sir.
put on monitor. Simultaneously, you will put on monitor, SpO2 monitor, isn't it?
Yes.
How you want to start oxygen? Means there are a lot
Sir,
of methods to start
point
oxygen. Probably you have learned. Yes.
0.5 to 1 liter.
Okay. So okay, we will see later. Then next what will you do?
Sir, next, sir, we will give one bolus at 10 ml per kg. For
So what
soft
about C? Then C for circulation, isn't it?
Yes, sir.
C for circulation. So then baby CRT is 4 seconds. So baby is in shock with cold extremities, as you are telling, or with poor peripheral pulses. Okay. So
Yes,
you
sir.
will provide a bolus probably. You will administer a bolus, saline bolus, 10 ml per kg.
Yes, sir.
And here specifically mentioned that no diarrhea. That means it is not because of diarrhea, isn't it? It is because of something else.
Yes,
Isn't
sir.
it? Good. So, severe respiratory distress, shock. So both are emergency signs. Stabilize the baby. Maintain airway. Warm humidified oxygen by nasal prong at 1 liter per minute. And as I have mentioned, immediately put on SpO2 monitor and titrate the oxygen requirement by the saturation. Or if you think that these things, CPAP or heated humidified high flow nasal cannula is available, then you may consider in that situation as well. And once you will put that, and then third point, so here we will discuss, so that is having started with oxygen, ensuring warm, you will put on cannula, then you will start with saline as you have mentioned correctly. Then after that, you will assess the baby. Okay, then probably baby may need repeat bolus or may need vasopressor. Okay, and then you will assess, examine the baby, and you will send some laboratory investigation to know the diagnosis, and then you will take care of that specific and further management, isn't it? Okay, good. So now we will discuss the case 3. Okay. Okay. So case 3, a 15-day-old baby with 2,900 grams is brought to SNCU with fever and abnormal movements for 2 days. Temperature 38 degrees centigrade, heart rate 110 beats per minute, respiratory rate 65 breaths per minute, no chest in drawing. Capillary refill time 4 seconds, extremity is warm, but the baby was convulsing. Okay, I'm going to again. Okay, thanks, Apurna. I am asking Anupama Mohanty. Anupama. Anupama. Okay, you were here. Arani Sen. Arani Sen. Okay, not responding. So if you are not responding, then it is difficult because simply if I am going through these slides, so it will not solve your problem. Okay. So here again, you know probably the child had fever, abnormal movements. So that means abnormal movements, but the baby was also convulsing at the time of examination. So that means convulsion is one of the emergency signs, you know. And here, though temperature is more than 37.5 degrees, so it is priority sign. But here, capillary refill time is also more than 3 seconds. So how we are going to manage? I am not seeing anybody, so that's why. Biswajit Mondal.
Yes, sir.
Good.
Yes.
Good, Dr. Biswajit. So can you tell what you will do in this? Sorry, I'm going.
Sir,
Yes.
as the baby has fever and abnormal movements, so we have to suspect meningitis. First, we have to
No.
see the.
Dr. Biswajit, again I am telling. So once you are getting emergency signs, you know probably first stabilize the baby before going to that. Though you know, first stabilize the condition, okay? And then probably you will admit, and then you will do some examinations further. Probably you will examine for fontanelle, etc. And then you will do some lab investigations to confirm your diagnosis. Isn't it? Don't jump to immediately to meningitis. Okay, that may not be the single diagnosis. Okay. So first you need to determine whether emergency signs are there or not. Okay, if emergency
So there is
signs
emergency
are there, then first stabilize the baby. Okay. So that is the purpose of triage. Okay, and then probably once you are thinking about stabilization, you will decide depending on your situation where you are working. Either you can admit straightforward depending on the situation, or you can do the stabilization in the casualty or in pediatric emergency. And then once everything is fine, then you will transfer the baby to your care, to your SNCU, and then further management, what you are telling. So you will take care of that. So then proceed further. Proceed.
So as the child is convulsing, so it's an emergency situation. So we have to admit the baby.
So you know, stabilization means it is TABCD: temperature, airway, breathing, circulation, and look for dehydration. So T for temperature. Here temperature is high, 38 degrees centigrade. Okay, so we need to take care of that. Huh?
Yes.
So it can be
Yes, sir.
because of the that disease what you are telling. It can be because of something else as well. So once, as you know, once you are stabilizing the infant, probably you will keep under radiant warmer or somewhere. So you need to take care of that temperature. Okay. Then airway, because baby is
So we have
convulsing.
to suction. Yes. So
Yeah.
we have to clear the secretions.
Yes. Good.
Use suction and ventral and neutral position. We have to use shoulder roll or keep the baby in lateral position if required. If there is lot of secretions.
Okay. They good. Then after airway, B for breathing. Then you will see whether baby is breathing spontaneously, as I have mentioned in the stem that baby's breath rate was something 55 something. Though
So
baby
we'll
is
see the oxygen saturation and start
Yes.
oxygen if required by
Yes,
nasal
good.
cannula.
Good. Then
Then
for
we have to
circulation,
check the CBG if the baby is convulsing
yes, as baby is
to see if there is
convulsing,
any.
we check CBG. So if you are getting hypoglycemia, you have learned today
We have
also
to
how
give
to manage hypoglycemia. So it is baby is convulsing means it is symptomatic neonate. So you need to give bolus 10% dextrose 2 ml per kg, isn't it?
yes,
And simultaneously, as baby's CRT is 4 seconds, so it is then you need to give another bolus saline.
10 ml per kg normal saline bolus.
Okay. And if blood sugar is normal, probably you can avoid that dextrose. So you will give simply bolus of saline, and then you can give calcium, IV calcium, isn't it?
Yes.
And then if still further there is convulsion, then probably you will start anti-epileptics medication.
Phenobarbital.
Okay, good. And then you will assess for dehydration as well. Okay,
Yes, sir.
because that is TABCD, na? So you will complete that. Okay. And then once baby is stabilized, what we have mentioned earlier, that you will assess the neonate further, and then based on your some laboratory investigation, like in this situation, as you are thinking, it could be sepsis, it could be meningitis, it could be something else. So you will do some basic lab investigations. Based on that, you will decide what is the diagnosis, and once you will know that it is because of meningitis or something else, so probably you will start specific as well as supportive care, isn't it?
Yes.
Okay, good. Thank you. So now we will move to the, so you know probably these tops or stops, these are mnemonics. So once you are sending any baby somewhere, or maybe once the baby is arriving to your side, so quickly to know how is that baby. So you usually this mnemonic: S for sensorium, T for temperature, uh, O for oxygenation, that means SpO2, P for perfusion, that is capillary lipid time, and S for sugar, blood sugar. So depending on these, so these 5 parameters we quickly check, and based on that we decide what can be done. Okay, so this is one mnemonic. Another one you know probably ABPU, that is alert, responding to voice, responding to pain, and unconscious, is not responding to anything. So if it is P or U, you know, so this is an emergency, isn't it? If baby is not only responding to pain or is not responding, that means encephalopathy. So these are emergency signs. Okay. Now we will discuss the case 4. We have only 4 minutes time. I am asking one person. Aroni Sen. Aroni Sen. Anupama Mohanty. Okay. Dilip Babu. Dilip Babu. Okay. Okay. Nobody is responding. A 3-day-old baby weighing 4,500 grams brought with refusal to feed and bleeding from umbilicus. On examination, temperature is 37 degrees centigrade, heart rate 140 beats per minute, respiratory rate 50 breaths per minute, CFT 2 seconds, icterus up to mid thigh. So how will you trace this baby? So that means here, if you know, so baby's weight is 4,500 grams. So that is priority. So you know more than 3,800 grams or less than 1,800 grams. Okay, refusal to feed and bleeding from umbilicus. So all are priority signs. So here temperature is normal, heart rate is normal, respiratory rate is normal, CFT is normal. Icterus up to mid thigh is also normal. Day 3 old term baby probably. So priority signs. That means you will assess and then you will treat. So your question is, does your hospital have a designated triage zone? So if you do not have, you can think of this. What is the ideal for neonatal triage area? Okay, so priority signs, what about jaundice in this baby, priority or non-urgent? So as you are not responding, so it is non-urgent, it is not priority. Okay, priority means jaundice, severe jaundice, staining of palms and soles and appearing within 24 hours. Refusal to feed needs a holistic approach and adequate assessment. It may be a simple nasal block to severe sepsis. So refusal to feed a big baby. So it can be that baby is having some kind of nasal block. So that's why baby is not taking feed or refusal to feed. Or it can be severe sepsis also. So that's why, because other parameters are normal. So it can be, means though chance is less likely. And the umbilical bleed could be either slippage, because it is day 3 baby. It can be also vitamin K deficiency bleeding. So here it is mentioned 2 milligrams. So you can give vitamin K injection if it is not given earlier, or even if it is given also, you can repeat the dosage. So here TABCD, again T for temperature. So first, as it is priority. So here, so question is, you will assess the baby and then accordingly you will treat. So here TABCD will not come first, means stabilization will not come first. So here from this assessment of the baby, you know, so it is the umbilical bleed because of vitamin K deficiency bleeding. So we will give vitamin K injection. So we have completed both the this module on neonatal hypoglycemia as well as the emergency triage assessment and treatment. So if you have any question, you can ask me. I don't think you have any question. Good night. Sir, good night. Sir, Dr. Nepal Mahapatru, sir, good night. Sir, yes, sir, you can unmute yourself, sir. Sir, unmute yourself. Yes.
Okay.
Sir, you
Yes,
see
sir.
that?
Yes, sir. Thank you, sir.
Yes, sir.
Thank you,
Sir.
sir.
See, sir, nobody is responding. Means this is first time I am taking this, but ask them to respond at least. I understand they are busy because somebody was in the auto, I have seen, and they are doing lot many things. Yes, it is allowed. It is not like that. But once they are listening or doing something, they must respond to learn something. Okay.
Okay, sir. Thank you, sir.
Yes, sir. Good night, sir. Good night, sir.
Okay, thank you. Thank you.